Good evening. Can I go ahead? I think so. Okay. Good evening, everyone. Thank you for coming. I am Dr. Anik Avali, Director of Student Research and Course Director for the Community Medicine Global Health program that we have here. And today we have a great opportunity to provide our students with a platform to showcase their spirit of inquiry. We have 6 students presenting. 5 of them are presenting research ideas. So these are ideas that they came up with on their own, maybe based on their previous experience or personal experience that they would have had over their years. So we have 5 presentations that are student ideas, and 1 is a completed project that a student will present as well today. The 5 student research ideas are the ones that will be judged. We have Drs. Benjamin, Dr. Hall, Dr. Puran sitting at the front, and they'll be judging our presentations today. So the first presenter is Kalia Harley from semester 1. And she'll be presenting on food insecurity and colorectal cancer.
Good evening, everybody. My name is Kalia Harley, and I'm a first semester student. Today, I'll be introducing you all to my research project on food insecurity and colorectal cancer. So can I get a raise of hands on who has heard of food insecurity? Cool. All right, so who believes that access to healthy foods can impact the overall health? All right. So this leads me to an important issue at hand, which is there has been an increase of incidence of colorectal cancer in the Barbadian community, and it is important to investigate this cause. One of these issues that I will be investigating is food insecurity. Food insecurity is a condition of not having access to sufficient food or quality to meet one's basic needs. They're influenced by income, race, ethnicity, or disability, amongst others, and can be long-term or temporary. On the other hand, colorectal cancer develops from certain polyps or growths in the inner lining of the colon. To connect these, 90% of colorectal cancers are caused by environmental exposures, which include low fiber diet and high fat diet, alcohol, and smoking. The impact that these have recently are that there has been an increase of food insecurity among COVID-19 pandemic. The prevention, management, and treatment of colorectal cancer relies heavily on dietary health and lifestyle, which brings me to my research question. What is the relationship between food insecurity and incidence of colorectal cancer in the Barbadian working class ages 18 through 65? I will be conducting this research using databases, one which includes the FIES Global Reference Scale to assess food insecurity, which is basically a questionnaire that you as an individual or household can do that assesses experiences with increasing difficulties in assessing food due to resource constraints. I will also be using the Barbados National Registry, which is a national surveillance system conducted by the Chronic Research Center on behalf of the Ministry of Health. The benefits of this study are that it can help with the development of policies that may mitigate the impact of food insecurity in Barbados and potentially reduce the incidence of colorectal cancer.
Another round of applause for Kalia, starting us off. We'll have questions at the end for everyone, so I'm going to allow everyone to present. And thank you, Kalia, for speaking to time as well. You did great. Next, we have Jonathan, who's also from semester 1. Jonathan? Oh, hi. You could advance here. This is quicker.
Perfect.
Yeah.
Great, thank you.
Yeah.
Can I take this off? Is that okay? Great. Hi, everyone. Good afternoon. My name is Jonathan Weinreich. I'm a first semester medical student here at Ross University, and I'm going to be talking about disease prevalence for prostate cancer in Barbados, West Indies. I'm going to start my presentation by giving the first line of every single prostate cancer study that's ever been done ever, which is, hold on, wait for it. Okay, which is prostate cancer is the most common cancer found in men and is associated with an extremely high disease-specific mortality if it goes untreated. Previous studies have been done on the prevalence and incidence of prostate cancer in Barbados. Back in 2011, there was a study, and also in 2015. They had slightly discordant results, which I actually thought was kind of interesting. In the US, obviously, this is a very well-studied topic because of its specific prevalence and incidence. One study, the study from 2011, said specifically that prostate cancer is lower than expected for an Afro-Caribbean population, and the 2015 study actually refuted the 2011 study and said that it's higher than expected for an Afro-Caribbean population. I suspect, not having actually done any of the research, but I suspect that there's probably some sampling bias going on in both studies. Because one of the issues in prostate cancer research, or with prostate cancer generally, is that number one, it can go undetected. There's actually a very interesting study 5-10 years ago that came out that said that 25%, it looked at autopsies in men ages 18 to 34, and it said 25% of those men harbored an indolent prostate cancer, which actually is very interesting, right? You wouldn't think to test an 18 to a 34-year-old for an indolent prostate cancer, but they actually do. They might be harboring it for long, long periods of time, long before the medical establishment would go and test them. Anyways, in the last 5-10 years in the United States, prostate cancer treatment has gone, really haywire, bonkers, both from an oncology perspective, from a surgery perspective, from even a radiation oncology perspective. There's tons and tons of different options. I was considering including like a video here where I just scrolled through the guidelines because it's about 150 pages now. And so in order to look at this disease, this kind of interesting disease in the Barbadian population, we're going to look at two primary objectives, or two research objectives. The first objective is we're going to look generally at the incidence and prevalence of prostate cancer here in Barbados. And then second, we're going to assess the current treatment modalities. Just from basic conversations that I've had so far, it seems like a lot of prostate cancer, or a higher percentage of prostate cancer in Barbados, is diagnosed later on, with things like pathologic fracture, which is where prostate cancer might metastasize to the spinal column, cause a fracture, which is, sort of really much, much further along than you'd want. And so we're going to do this in three ways. The first is we're going to survey some local physicians who treat prostate cancer here in Barbados. That could be oncologists, urologists. Second, there's a Barbados urologic diseases survey database that we're going to look at and hopefully come to some sort of understanding of the histologically confirmed cases. Is it more common to have a higher grade cancer in Barbados than a lower grade cancer in Barbados compared to that in the United States? And we're, since this topic hasn't been studied since 2015, I think it would be kind of interesting to look at the last 8 years of prostate cancer here. Wait for it. Okay, great. And then finally, just to sum up here, there's, I mentioned sort of offhandedly earlier that there's many, many interesting prostate cancer treatment modalities available in the United States, right? For occult metastases, there's what's called a PSMA PET-CT that's just been developed and approved in the United States. There are all of these new oncologic drugs that are available. I would suspect that a lot of them are probably not yet in use here in Barbados, which is kind of interesting, right? I think that could itself be its own study about the use of specific oncologic drugs in the treatment of prostate cancer. And then hopefully at the end of this study, we'll come to some sort of conclusion or some sort of summation as to what could be improved in prostate cancer treatment in Barbados. Great, thank you.
Thank you, Jonathan. Great job. I'll add here that our presenters, the ones that are presenting their research ideas, are being judged on whether the judges deem the project to be feasible, interesting, novel, ethical and relevant. So those are the kind of parameters that they're being judged on, and they'll make any comments that they want to and give them back to our presenters in time. So the next presenter we have is Marcus Harrison, who's semester 4. And Marcus will be presenting on congenital heart defect-associated neonatal infant deaths in Barbados.
Good evening, everyone. My name is Marcus Harrison. I am a semester 4 student here at RUSM, and my research topic is an evaluation of congenital heart disease-related deaths among newborns, specifically in the Caribbean and West Indies. So congenital heart disease is a leading birth defect with the highest risk of mortality. 1 in 125 newborns are born with a congenital heart defect, which equals about 1 million babies per year, of which 70% require treatment or surgical repair. Furthermore, 1 in 3 newborns die within their first month of life without treatment. In a 2019 study completed by the Global Burden of Disease, there were a little over 200,000 reported deaths associated with congenital heart disease. In the United States specifically, there were some additional racial disparities identified, with Black infants being disproportionately having the highest mortality rate, followed by Hispanics. In the Caribbean, however, there is limited research and data available, and the data that is available loops the Caribbean in with Latin America, kind of skewing the results. So currently we are unable to evaluate the prevalence and mortality rate for the 13 Caribbean islands. This table right here is just showing some of the top congenital heart defects, with structural congenital heart disease and bicuspid aortic valve being at the top of the list. So 66% of preventable diseases associated with congenital defects are due to congenital heart disease. The main issue for the Caribbean specifically, and many other developing countries, is there's limited access to screening, treatment, and surgical repair. Most patients with severe CHD residing in the Caribbean must be transferred abroad due to inadequate availability of cardiac surgeons or treatment centers. If you take a look at the table to the left, you can see the ratio of surgeons in relation to the general population for each continent, with it being roughly around 1 surgeon for every 3.5 million individuals. Due to this, roughly 40% of patients experience gaps in their care, with 60% experiencing a loss to follow-up. This image right here demonstrates the death rate grouped by age and general socioeconomic status of each country. As you can see, the highest mortality rate is consistently during the neonatal or postnatal period, which is at the bottom of each graph. However, in highly developed countries, which is the last graph to the bottom, you can see that there's a slight reduction in mortality rate in the most recent years. Specifically, in the United States, there has been a 40% decrease in mortality from 1990 to 2019. However, that information is not available for the Caribbean. Therefore, I aim to answer the question, is there a disproportionate rate of congenital heart disease-related deaths among newborns in the Caribbean or West Indies? Specifically looking at newborns up to 1 year of age, evaluating the mortality rate and available treatment interventions, including follow-up in comparison to the United States. Long-term, I hope to establish a standard guideline for all 13 Caribbean islands to increase the survival rate of newborns with CHD. And that concludes my presentation. Thank you.
Great job, Marcus. Thank you. Next, we have Arkit Kumar, who's presenting on depression and coronary artery disease. And he's on semester 5. I'm sorry. You can present here. Press this one to go forward.
Hello everyone, my name is Arjit Kumar Prajapati and I'm semester 5 student here. So the research topic that I'm interested in is the association between depression and the coronary artery disease. The reason I selected this topic because during my experience as a medical scribe prior to joining the medical school, I noted that many teenagers were diagnosed with the depression and were on the antidepressant medications. And as an aspiring cardiologist, I wondered like if there is any risk associated with depression of them developing the cardiovascular diseases in the future. So if you look at the graph, anytime. Okay. If you look at the graph here, by the Journal of American Academy of Pediatry, it showed that the prevalence of depression in adolescents in US was increased by from 8.7% to 11.3% by 2014. And prevalence of depression in young adults was their age was like early 20s. So it was from 8.8% to 9.6% by 2014. Another study showed by the British Journal of Clinical Psychology that showed that global point prevalence of depression in the adolescents was increased from 24% to 37%. And the meta-analysis done by BMC Psychiatry showed that there is a relative risk of 1.3 in cardiology for coronary artery disease and MI in association with the depression. So as we can see that there is a trend of increase in the depression overall globally as well as in the US. Now if we talk about the risk factor associated with the depression, okay. So there is a direct association as well as indirect. So direct would be like pathophysiological changes such as endocrine functions, as well as like oxidative stress. So circular by American Heart Association, their article showed that there is increased aortic stiffness as well as increase in blood pressure noted in the healthy adolescents patients of the depression, as well as they noticed sleep disturbances, weight gain, as well as according to the Journal of Epidemiology, it showed that there is decreased sleep among the patient, as well as increased weight gain, and they perceive themselves as overweight as well. And the medications such as antidepressant, they also tend to increase the weight by various mechanisms. So the way I plan to do this study is doing a retrospective study. So sample would be the patients with coronary artery disease between the age of 40 to 60 who have depression, and the control would be the patients of the similar age with the coronary artery disease who do not have the depression. Another method would be by the meta-analysis, but the limitation is that there is not enough recent studies done. So it's not very feasible to do the new meta-analysis regarding that. And another approach would be the prospective study, but that would take like few decades to do that study. That's why, so the question would be, okay, are adolescents who have been formally diagnosed with the depression at an increased risk of developing the coronary artery disease within the 30 years of the diagnosis? Thank you.
Thank you, Archit Kumar. So, very good study or idea. I would like to say also that in addition to these presentations, there are also some posters around. You'll see some easels. I think there are about 6 around of posters, and you can take a look once this is finished. So I just wanted to alert you to that as well. Judges, is the pace okay? Are you guys keeping up? Yes? Okay, thank you. Next, we have Christopher, who's from semester 1. We have lots of semester 1s today. Oh. And Christopher will present on ADHD and the autism spectrum. You can press this one to advance it.
Are they going to put it up directly now?
Yeah, you can go ahead.
Hello, everyone. Thank you for joining me here tonight on a topic that's very near and dear to my heart. I've really been ruminating and thinking about this topic for years and years, especially through my, experience working in the psychiatric field alongside my father and many other psychologists and therapists. So thank you for allowing me to present this today. So, throughout my experience where I just listed, I came up with sort of this theory that ADHD is not really a mental illness that exists on its own. Rather, I strongly believe that it is something that's on the autism spectrum, and it's essentially a mild form of autism, and I'll sort of elaborate more on that. So, where this all started was a few years back. I met a very brilliant guy. He ended up going to University of Chicago. He was that brilliant Ivy League guy. He was very high functioning autism, and meeting him was kind of my first start in this because I'll admit I have ADHD, right? And it was weird because when I met this guy, I noticed I did a lot of the same things that he did essentially, and one of the main things that it was just the rumination and the deep thinking, which basically the root of this constant rumination and deep thinking is, sorry, I'm trying to move the slideshow. So it has to do with the default mode network, right? So all I'll say is it's been well established, especially with ADHD, but now they're really starting to understand with autism also is this dysfunction of the default mode network, right? So what is the default mode network? The default mode network is where your mind is when it's not intensely focused, right? So your default mode network is triggered when you're laying in bed at night, you're thinking about your day, you're thinking about the future, you're thinking about things to come. That is what, the default mode network is essentially. And what we see is that in both autism and ADHD, there's over-triggering of the default mode network, and multiple neurological studies have, shown this correlation. And it's just astonishing to me because through all my literature review I've done, on this topic, whether papers talk about autism or ADHD, when they're scanning the brain activity of autistic and ADHD individuals, you're seeing this over-triggering of the default mode network, and it's just incredible to me that no one's really, put two and two together. And, one thing I want to say about the default mode network is we know, it's overactive in both ADHD and autism because of the medication we use to treat it. The first line treatment for both of these mental illnesses is, usually amphetamine medication or any kind of stimulatory medication, because the point is we want to take these individuals out of the default mode network and into, that executive functioning. So. And, besides kind of the neurological evidence of these things being related, I also want to discuss sort of the behavioral evidence, right? So when an ADHD and an autistic individual show up for therapy, right, the first thing that the therapist or the psychologist is going to tell them is that you need to live a very structured lifestyle, and your life needs to have regimen, and it needs to have certain things that are repeatable. Waking up at the same time every day, eating at the same time every day, studying at the same time every day. And, you ask any therapist, this is what they tell both autistic and ADHD individuals. And, again, it's just astonishing to me that with these behavioral similarities and this type of effective, behavioral treatment they get, that, two and two really hasn't been put together. So I kind of mentioned this before, in the beginning of my presentation, but the main thing you see with ADHD and autism is this excessive rumination, or this kind of eccentric overthinking of things, right? So, with an autistic individual, you see this through stimming behaviors, right? Through obsessions, with certain topics. You see this with ADHD people. My opinion, these behaviors, these ruminations that they do, this is essentially the same behavior. It just slightly, we just categorize it, slightly differently. And another point I want to bring up is, a lot of people and a lot of papers will make little Venn diagrams, will do little comparisons between autism and, ADHD. And a lot of things are overlapping. So if you see my presentation where I put the arrows, it says with autistic people, they require routine and regimen. But if you say that doesn't apply to people with ADHD, also, that you're sorely mistaken. Ask any psychologist. With regards to social rules, also, a very high rate of ADHD people also have, issues with, following social rules or understanding social cues. And I'm running out of time, so I don't want to get too much into that. So, I say these things, these overlaps, right? I truly believe that ADHD is just a mild form of autism, right? And what's happening in the field now is because of all these, overlaps between autism and ADHD, we're seeing this rise in this thing that people call ADHD, which is basically just a dual diagnosis that clinicians give, mainly children if they have both autistic and ADHD traits. And, in my opinion, this is just kind of putting a Band-Aid on, a bigger issue. It's not the right diagnosis, just saying, okay, this person is both autistic and ADHD if they have these, crossing over of symptoms. So, I beg to differ in my approach to that. So, what I plan on doing, and I sort of started this during my undergraduate career, is I plan on conducting a large-scale, kind of like a meta-analysis, on the field on everything. As I showed you guys before, I'm really far along in kind of putting together neurological data that shows the similarities between autism and ADHD. But my next step is to, just incorporate more and more data, especially more of the behavioral data, and treating those kinds of things. And hopefully once this meta-analysis is done, then by residency, and I do plan on going for psychiatric residency, I'll be able to do a true in-person study with participants, which will examine the similarities between, autism and ADHD. So these are my sources, but thank you so much.
Thank you, Christopher. Like I said, we'll have time for questions after this next and final presenter, who's presenting a finished project. We have Ardra, who's presenting Huddle Rounds, Effect of an Interdisciplinary Stroke Consult Service on Transitions of Care. You can use this one to press. Which one? That one. This one. Yeah. Perfect.
All right, y'all. My name is Ardra. I'm a fourth semester medical student, and I'm from Dallas, Texas. So we're almost done with our Monday. So students, faculty, staff, everyone just take a deep breath. We're almost there. Okay, so my title is Effective and Interdisciplinary Stroke Consult Service on Transitions of Care. So if we talk about transitions of care, it's kind of the shift in care between disciplines, right? So when a stroke patient comes into the hospital, they're seen by a variety of specialists, as well as, nursing, occupational therapy, physical therapy. They're seen by all these people, right? But it's usually like independent, right? You go see the neurologist, and then you're done. That consult is done. You go see the rehab physician. You go see the speech pathologist, right? And it's all like these independent events. And so there's been this like push towards kind of a continuum, right? Where all of the types of care, like they interact with each other. They have like a dance where like they're able to like communicate with each other in order to kind of deliver a higher quality of care. Okay, so just some background, right? Stroke is a very multifaceted disease process, right? You have different things that are affected, like consciousness, vision, sensation, movement, and language, right? And so when you have someone who comes in with stroke, each person is affected a different way, right? You might have someone with speech impediment come in. but then, their movement is completely all right? You may have someone who is able to like cognitively process everything, but then they're not able to talk. So, there's like a variety of like the type of stroke patients that come in, right, for acute stroke. However, I'm sure a lot of you have heard the phrase, time is brain, right? Which means there's only a limited time in order to kind of assess and provide care for these type of patients, right? And so the different specialties that handle the variety of like symptoms or presentations that stroke patients come up with are definitely ER, acute care, surgery, physical medicine, social services, physical therapy, occupational, and then speech language, right? So as I mentioned before, some of the challenges in this continuum of care is that these different disciplines operate in these silos, right? It's like, the neurology office is completely separate, right? They see this patient and then, they send them off to the next physician or care team that takes care of them, right? And there's not as much communication between them, so different silos, right? And so another issue is like inconsistent records, right? So usually the patient comes in, they have like the neurology consult, and then they're discharged, right, from the neurology department. And so that record is like completely different from like when they see the occupational therapist, right? So there's no like connection between records per se, right? And so you can imagine that this kind of like disjointed care is very different from like the holistic care that would benefit patients if like these different disciplines were to communicate and speak with each other, right? And so kind of the macro effects, or like the big idea effects of these silos, right, are that there's a lack of standardization in the process, right? So like I said, time is brain, and so you want a very effective, very streamlined method in order to bring patients in, assess their needs, and then, send them to the departments or get them the treatment that they need, right? And so when you don't have like kind of that flow or that communication, this standardization is not there. And you definitely see, minority communities, underserved populations, they're hit by this more so, right? It definitely affects the hospital in terms of like cost of burden, readmissions, and then like repeated tests and treatments because there's no like link, right? And more importantly, there's the effect on like Medicare and Medicaid coverage. And so a lot of these stroke patients, they're within the range to get Medicare and Medicaid, right? And so because there's a reduced emphasis, right, on the continuum of care, it's possible that from state to state or from hospital to hospital, there's certain services that aren't covered under Medicare, Medicaid, right? And so that, as you can imagine, also affects the outcomes for the patient. And so kind of the two main things of this study was to evaluate the physiatry-directed stroke consult, kind of the rehab-directed service on access to rehabilitation post-stroke, right? And then the added bonus was I was able to work with my team to create kind of a virtual rounding tool. And so basically, like, you have the EMR, you have different specialties who use the EMR, but then it's kind of like creating like a unified systematic kind of like case or like a file where you're like, okay, stroke transitions of care, right? I go to like this specific area and it gives me all the information, right? The patient went from ER and then they were admitted to the ICU and then they went to rehab, they came back, that sort of thing, right? Kind of like a streamlined report for that. And so we called that the huddle rounds. And it's a combination of like the human aspects, right? Having like the different specialties interact with each other in order to provide the best care, as well as the use of like our EMR systems, which we're becoming more and more reliant on. So this is kind of like the outline, right? So basically the flow, or like the huddle, right, was that the patient was consulted with stroke and neurosurgery, and then they have like an clinical overview and a plan of care for the day, right? And so the charge nurse identifies potential barriers to this plan of care. Patients who need basically like inpatient rehabilitation or like nursing facilities or anything else. are identified at this point. And so social work comes in and they discuss the plans for discharge or for the next level of care for this patient. And then the patient navigator, or kind of the patient rep, ensures that follow-up appointments are scheduled, that the patient knows where they're going, when they're doing it, that sort of thing. And then social work also kind of approximates the discharge times and communicates it with the team to make sure that, the care process is on track. And so in terms of the virtual rounding tool, these are just some of the things that we pulled, just like imaging, echocardiogram for stroke report, for PT/OT for the therapies, things like impairments, family goals, therapy frequency that's recommended, that sort of thing. We also looked at discharge planning, current medications, admission details, and then like hospital or non-hospital, like so if they're being discharged from this hospital and going to another hospital, that sort of thing. And so like that's what the virtual rounding tool kind of consisted of. And so we prospectively collected data on these acute care patients, about a little over 1,000 from 2018 to 2020. And so basically, the physicians physicians and care team, I should say, followed this flow or the huddle, right? And they were able to use the virtual rounding tool in order to consult on their ischemic and hemorrhagic patients. And so overall, we saw more patients who were able to, be directed to the appropriate level of care, right? There was also like a heightened communication among members of the care team, which definitely influenced the number of patients who were able to get rehabilitation services. So some important considerations were the hospital setting and stroke center. So different hospitals have like different levels of stroke care, rural versus urban, that sort of thing. And so like we also considered that as like part of our sampling. And so our basic conclusion was that kind of the use of these standardized tools and this kind of flow process allowed for like structured communication between the clinician teams, nursing. There was a decrease in the number of errors, and then also an open exchange of information, which was used by the individual clinicians and providers, as well as like the healthcare system as a whole. And so our conclusion was that the implementation of the huddle rounds was pretty effective. So it increased referrals to rehabilitation, and then it decreased referrals to patients who had severe stroke just being discharged to home or just to a nursing facility. And next steps include validating the model so that more hospitals can use something like the virtual rounding tool or use the huddle round format and adapt it to their local circumstance. So, thank you.
So those are all of our presentations for today. Give another round of applause for all of our students. I hope next time we have some representatives from semesters 2 and 3. So hint, hint, just kind of keep that in mind for next time. So now we have about 10 minutes for questions from the audience for any of our presenters. I would prefer if our presenters come to the stage just for ease in terms you have to ask a question. So can Kalia, Jonathan, Marcus, Archit, Christopher, Ardra come forward, please? So now we ask, the floor is open for questions to our lovely presenters. If the judges want to start, they can if they have any questions, or anyone else here can ask. No questions? No one is going, oh, Dr. Ford, I'm so sorry.
That's all right. So first, congratulations to all of you presenters, and
I've been really impressed with the quality of the presentations. Now, for the second presentation on prostate cancer, I'm sorry I forgot your name, but I know it's you. Again, okay. Jonathan, okay, good. You indicated that you were going to estimate the incidence and prevalence of prostate cancer, but you also mentioned that there are undetected cases in the population. So how do you go about estimating the incidence in that situation? It's a trick question.
No, it's a great question. It's actually it's a significant research problem in the U.S. too. What researchers in the U.S. have done recently is subdivide prostate cancer into clinically significant prostate cancer and clinically insignificant prostate cancer. If you know the lingo a little bit, it's Gleason 6 as clinically insignificant prostate cancer, and then Gleason 7, 8, 9, 10. 3 plus 4, 4 plus 3, et cetera, is clinically significant prostate cancer. That prostate cancer usually gets detected over 90% of the time. The Gleason 6s usually don't, right? The common phrase that you might hear is you die, quote unquote, with prostate cancer rather than from prostate cancer. And so I think that probably in a finalized research project, we would subdivide the incidence of prostate cancer into clinically significant upon presentation, clinically insignificant upon presentation. And obviously there's treatment differences there, right? Usually clinically significant prostate cancer is treated, surgery or radiation, or sometimes chemotherapy, and clinically insignificant prostate cancer is usually managed, at least in the US, with what's called active surveillance. Does that answer your question? Great.
Thank you. And I think we were getting a signal to come across a little bit more to our presenters. Yes. Any other questions from the audience? Dr. Daisley.
Is it on? Oh, yes. Once again, excellent presentation by all of you. You guys did an amazing job. And my question is for Arkit Kumar. I wanted a little bit of clarification regarding the methods of your study. You mentioned that you were going to start by identifying persons with depression and then retrospectively look back to see if they had coronary artery disease.
No, it would be the patient with the coronary artery disease and look back whether the patient had a depression in the past and is it associated with that, and also considering the other confounding factors like if they already had a prior conditions or not, or they develop it after diagnosing with the depression, that would be also associated with those factors as well.
Thank you.
I think I had another question in this area. Oh, yes.
Hello. This question is for everyone. Why did you choose the topic that you chose?
Oh, Kalia, you can start.
So I chose my topic because I have a GI issue, and I know my GI issue, which is IBS, it revolves a lot around diet and FODMAP, and it helps manage the symptoms that I have. So I want to connect how food insecurity, which is a vital thing in our overall health, and how it can affect colorectal cancer.
Okay, as I said earlier, I want to be a cardiologist, and during my medical scribe experience, I saw many teenagers who had diagnosed with depression and taking antidepressant medication. So that just made me curious, like if there is any risk associated with for them that they could develop the cardiac disorders because of the depression.
And again, great question. Prostate cancer, to me, is one of the most fascinating cancers, partially because of what I just told Dr. Ford, right? So much of prostate cancer today, you just tell the patient, you have cancer. I promise you have cancer, but we're not going to treat it. And so that sort of dissonance between you have this cancer, it may or may not kill you. Also, we're going to do nothing and we're just going to watch and wait. We might do another biopsy, another MRI in a year, but for now, we're not going to do anything. I think is a really interesting, and I've seen that firsthand shadowing urologists. I've seen how patients react to that, and it's sort of really an interesting arc for research nowadays.
So the reason why I chose my topic is because statistically speaking, straight up, people with ADHD do not do very well in society, and that's just what the numbers say. People with ADHD have a much higher suicide rate than your average person. They have a much higher depression rate. They have a much higher anxiety rate. And, if you look at their upbringing growing up, within the school system and stuff, the schools don't handle ADHD people correctly. The way it is, you see a lot of them fail out at much higher rates. And what it comes down to is people just don't understand ADHD. They don't understand like what this disease is, and I believe it's a part of the autism spectrum, and it's not being treated as such. So we're just allowing people to suffer. We're giving people who are suffering bad advice, and at the end of the day, what always keeps me going is, I always think of that suicide rate, among ADHD people, and I think, hopefully what I'm doing, the work I'm doing can maybe, save a few lives. So thank you.
I chose my research topic because I specifically have a interest in pediatrics and pediatric cardiology. As we know, heart disease is very common in the Black community. I was unaware that congenital heart disease was disproportionately affecting Black infants. So when I came across, that along with the disproportionate rates amongst Caribbean islands and developing countries, it really just sparked my interest. And then when I looked at the literature that was available, I was able to identify a knowledge gap. So I just feel like it's a very important issue to look into and fill that knowledge gap so we can increase, like I said, the survival rate of infants that are suffering from congenital heart defects.
Yeah, so for my topic, it was kind of a combination of like all the things I'm interested in, using technology to improve healthcare outcomes, improve quality of life. Also, like, I'm very interested in how like different disciplines communicate with each other in order to provide care, because obviously a lot of the diseases that we learn about, it's multifaceted in terms of like organ systems, and so you have different specialists working together, and so this is just kind of an exercise in that, so that's why.
Great responses, guys. I will take maybe one or two short questions before we finish this section. Dr. Ford.
I have a question for Marcus Harrison, and this is probably something that every student has to think about. How do you go about finding the population you're looking for?
That is, sorry.
Yeah.
That is a great question. I believe my first task would be to connect with a cardiac surgeon that is on island, and with him or her, identify what treatment options are actually available on island. Maybe also identify a database that has the mortality rate across all the islands. May take some work to be able to identify those platforms, especially with the lack of research that is available, but that's pretty much my first step, would be to connect with a pediatric cardiologist on island and hope to identify different platforms that will help me figure out where exactly the problem stems from and what treatment options are available.
Yeah, let me just comment very quickly. You talk about congenital heart disease. In this case, this is one of those situations where surgery really matters. I have a brother who is a surgeon. I hate admitting that to him, but but that is the case. And I suspect that in low-income countries and resource-poor environments in general, that surgery is really probably not available. It would be interesting to find out, to see what you learned from there, but we can also connect you with folks in the United States who can help you address the kinds of questions you're posing. But very interesting.
Thank you.
Let me check my time. One more small question from anyone. Okay. Okay. Jonathan.
Why did you only pick the doctors who are urologists? I can't remember the other doctors that you wanted to use, but do you not want to open it up to other doctors?
I don't know if I fully understand your question, but I'll repeat what I said, maybe just to clear it up. So the people who treat prostate cancer generally are urologists who are surgeons. They can do a procedure called a radical prostatectomy. Radiation oncologists who can do radiation therapy that can be external, that can be internal, a procedure called brachytherapy. where seeds are implanted in the prostate. There's even some newer things you might have heard or seen an ad for CyberKnife in the US. And there's also oncologists or medical oncologists that treat systemically with chemotherapy. So those are the three kind of physicians that I think we're going to restrict this study to, just because they're the most common treaters of prostate cancer.
Thank you. Thank you for all those great questions. So another thank you to all of our presenters. Thank you guys for being so brave and stepping forward. I think you did fantastic. I think this kind of showcase as well that our students have a life that before they came here, and it's really interesting to see how their lives before and their experiences before can impact their curiosity as they continue to grow as budding medical professionals. We do have some participation certificates for our presenters that we can just give out quickly. Do we have them? So Dr. McIntyre will help me to give them to our participants while I talk to the judges after this to kind of see what we have in terms of a winner, and that winner will get their prize during the award ceremony. Names? Okay. So first we have Kalia Harley. Thank you. Great. We have Jonathan Weinrich. Another semester 1 representative. We have Marcus Harrison, semester 4. We have Archit Kumar, semester 5. We have Christopher, semester 1 again. So many semester 1s, how great is that? And we have Ardra from semester 4. Great. So thank you. That's it for the research part. Over the next 15 minutes, you guys can take a look at the posters around. I think the authors of some of these posters will be around somewhere, and they may stand up near their posters once they are present. I asked them to be. And I thank you for your attention and your engagement in this session, and I look forward to next time. Thank you.
So now we come to the second part of our event. Good evening, and welcome to Ross University School of Medicine's Fall 2023 Honors Night. Too often, we are focused on achieving, and we forget to acknowledge what we have accomplished. For this reason, one night each term, we set aside time for us to pause, reflect, and recognize your achievements. Tonight is that night. So while you are here, take a moment to catch your breath, connect with your colleagues and faculty, and refuel with some food and drink. I hope you are also able to support your classmates in the just concluded RUSM Symposium event. Our first area of focus is on your academic achievements. Momentarily, Dr. Ford, on behalf of our faculty, will recognize those students who have made the Dean's Honor Roll and Dean's List. Immediately following, representatives from our Student Government Association will come forward to present awards to recognize your co-curricular contributions and achievements. In the past, Dr. Hayes, our Associate Dean of Student Affairs, has issued a challenge to faculty, staff, and administration to present other kinds of academic and non-academic awards at Honors Night. I am very, very happy to state that tonight, Dr. Hayes' challenge has been accepted. For the very first time, the Honors Night will also include the Micro Symposium Awards from the Office of External Affairs. The Student Affairs celebrates student academic collaborations through the Ambulatory Healthcare Experience, AHCE program with Dr. Sinal Mehta. And 3 Learning Community Awards will be presented for outstanding student leadership, outstanding colleague, and community engagement. We have an exciting time before us, so let's get started. Please welcome to the podium Dr. John Ford, Ross University's Senior Associate Dean of our Barbados campus, to present the Dean's Honor Roll and Dean's List certificates for the summer 2023 term. As you hear your name, please make your way to the stage. And please be reminded that students who have completed medical sciences, that is, those who would have been in semester 5 for summer 2023, will receive an electronic certificate. Dr. Ford.
First, let me say that this is an amazing day here. It's an amazing day for me because this is a celebration of excellence. We just saw some students come here, initiated projects, some really provocative research questions, and I think I was really excited to see that, and here we are doing more of the same. So it's really my pleasure to celebrate Honors Night with you. And when I talk about excellence, it really speaks to choices that people make. You're not born excellent. You choose to apply yourself, and that's what we celebrate today. I myself, I'm very honored to be a part of this because this ceremony recognizes accomplishments that reflect our values and morals, and which the awardees exemplify. They have applied themselves, they have done the work, and that's why we recognize them for their discipline, compassion, community engagement, and their zeal for learning. So within the last year, Ross University School of Medicine has expanded, as you heard, the honors program with some additional areas of recognition. So we are very, very pleased today to offer these awards. And for the Dean's Honor Roll and Dean's List, here are the criteria. First, recognition of exemplary grades. The students earning exemplary grades are recognized as follows. Medical Sciences Dean's Honor Roll. To make it, you have to be a student who's earned a high pass in Foundations of Medicine course and a pass in Clinical Skills course in semester 1. If you have done those, you may qualify for the Dean's Honor Roll. For the Medical Sciences Dean's List, it recognizes during the medical sciences semesters, students who have maintained a 3.5 GPA in 2 successive medical science semesters. So if you've done that, you qualify for the Dean's List. They remain on the Dean's List as long as they maintain a 3.5 GPA and above, of course. Nothing wrong with that. Each semester. The Dean's List is posted at the beginning of each semester as soon as grades are available. Semester 2 students are eligible to be on the Dean's List if they have a 3.0 GPA for semester 2 and earned a high pass during semester 1. Thank you.
Prabnor Chatwal. Devonveer Graywall. Janaya Joseph. Jaden Yamakazi. Mahmood Duragme. William Shears. Hazem Afas. Casey Moby Achike. Lane Archangel. Cameron McPherson. Stephen Richards. Ashware Atafo. Jared Hood. Hassan Salman. To be Yang. Evan Baker. Emilia Johnson. Ayana Dominique Montague. Rachna Patel. Usman Kazi. J. Swami. Michael Walsh. Gabriella Kazaza. Ashley Montgomery. Christopher Roberto Quispe. Inkiru Enigbogu. Fatima Belkacem. Caleb Bonsu. Chedis Joseph. Jenna Kindig. Archit Kumar. Trevenna Matthias. Zeke Omoruyi. Alexander Michael Preissig. Sophia Sadiq. Dakota Top. Madison Whitney. Ariana Alexis Freeman. Michaela Galusha. Elnora Duyen Min Wen. Olamide Ologundudu. Jennifer Eje. Leonard Stokes. Kyle Burwise. Zihao Kai. Connor Chitsey. Carissa de la Cerda. Vivek Kapadia. Ritvik Malareddy. Jovana Milutinovic. John Joseph Mernon III. Sean Rockwell. Maria Joselina Saruca Villanueva. Peter Wong. Colby Frank Williams. Rupert Williams. Michael Zajac. Leah Dejani. Mariana Saor. Rula Ibrahim. Tanvir Atwal. Keegan Church. Aaron Dolan. Benson Gladison. Adam Weber. Michael Luai Atari. Colton Blackwell. Love Echema eBay. Taylor Aspen Spencer. Chow Steve Vang. Bailey Hollingsworth. Olivia May. Trupti Patel. Ann Joseph Pham. Giovanna Rutherford. Ryan Merez. Angia Aswani. Sydney Lucila Jimenez. Ernest Walter Metellus. Jordan Redden. Nikhil Guile. Elijah Jamil Hawkins. Hardin Johnson. Purna Magar. Pavlo Navrota. Patrick O'Dowd. Harsh Patel. Lucero Rendon. Rainice Edie. Neha Aurora. Roxanne Branford. Noi Hasid. Stephen Hurst. Luka Szczepanik. Panis Taheri Faliani. Mohammed Mokhtar. Nicolette Okoro. Suez Oramas Gonzalez. Crystal Scott.
Thank you so much, Dr. Ford. Congratulations to you all. Before we move on to our Student Experience Awards, I want to add one more layer of acknowledgement for those who have made the Dean's List. By show of hands, can we see our first-time honorees? Woo! How about the seconds? Those who've been here twice already. Can we see a show of hands? Nice. For those who have been here for the third time. How about the fourth? And the fifth? Soon enough. Okay, congratulations again, students. This brings to mind two challenges that Dr. Hayes issues to all honors recipients. First, we want to see you here next term. If you are an 05 student, we want to see you on the clinical dean's list in a year. And second, and you've heard Dr. Hayes also say this many times, pay it forward. Look around at those who are here. More importantly, think about who is not. A study partner, a roommate, a friend. How can you pay forward your skills, abilities, and knowledge to others over the course of the next few months to help them to get over that hump to join you here next time? Although this honor is exclusive, there is no cap on the number of students who can join in this achievement. We'd be more than happy to get a bigger space. Now, I am very excited to transition to our Student Government Student Experience Awards. To do the honors, please welcome your SGA President, Bobby Cavett.
The SGA Student Experience Awards are designed to honor student organizations and individuals who have made an outstanding contribution to the RUSM community through their involvement, service, leadership in the summer of 2023. We had over 45 submissions last semester. All right, so our summer 2023 winners are, first we will be doing the Club of the Semester Award, which recognizes one organization that worked to fulfill their mission, offer opportunities, and support the RUSM community and made a significant impact on the campus community. This semester, this award goes to Phi Delta Epsilon. The next award would be the Barbados Impact Award, which recognizes a club that has put an event that has positively impacted the Barbados community. This award goes to the OBGYN Interest Group. Next, we will have the Outstanding Academic Event Award, which recognizes a club that has put on an event that has been academically or professionally beneficial to the RUSM community, student community, which goes to the Ross EMS Interest Group. Next, we will have the Outstanding Multicultural Event Award, which recognizes a club that has put on an event that has raised cultural awareness for the RUSM community. And this award goes to the LGBTQ Doctors Association. Next, we will have the Outstanding Wellness Award, which recognizes a club that has put on an event that focuses on student wellness and has positively impacted the RUSM community. This award goes to Lifestyle Medicine Interest Group. Next, we will have the Club Leader of the Semester Award, which recognizes a student leader who has had a significant impact on organization success and campus community through their leadership. And this award goes to the President of the Phi Delta Epsilon, Jillian. And finally, our Heart of RUSM Award, which recognizes 2 students per semester that go above and beyond to positively impact their RUSM community and make RUSM a better place to be. These 2 awards go to Gabriella Kazaza and Alexander Pricing. Thank you.
Thank you, Bobby. And thanks to the SGA for the hard work and dedication you show as student leaders. And congratulations to the SGA awardees. It is now my pleasure to request that our Senior Associate Dean from the Office of External Affairs, Dr. Rhonda McIntyre, come to the stage to present the Micro Symposium Awards.
Thank you, Dr. Prasad. Good evening, everyone. This is a little bit more than the OEA Micro Symposium Awards. This includes some community awards that we'll be giving out to some of the students who have participated in various engagement activities. But we will start with the Micro Symposium Award. So, this is named the Community Connections Research Award, and it's awarded to the individual who has presented the best research idea at the Micro Symposium. I hesitate to say that because all of the ideas were fantastic. However, we have one winner. This project is one that will add scientific knowledge and potentially inform healthcare in Barbados. This award goes to no other than Marcus Harrison. All right. So this other award is the Health Awareness and Promotion Award. This award recognizes an individual who has contributed significantly to building healthier, more resilient communities through health promotion and education in Barbados. This award goes to Ngozi Ugbo. All right. So I hope that's encouraging everyone to participate in the OEA engagement activities that we've been emailing out to you guys and research. All right. This award, the next award is for Service to Vulnerable Communities Award. Service to Vulnerable Communities Award. This award recognizes an individual who has made an outstanding contribution to supporting marginalized and vulnerable communities in Barbados. This award goes to Kelsey Sapida. In fact, Dr. Prasad will take over.
Thank you, Dr. McIntyre and team, for these crucial personal and professional development opportunities that you provide. And congratulations to the Micro Symposium awardees. I now invite Dr. Sinal Mehta from the Ambulatory Healthcare Experience, AHCE program, to read the names of our Student Affairs Celebrates Student Academic Collaboration awardees. Dr. Mehta.
Good evening, students. So now I will be reading the names of the students who have had their excellent contributions in creating presentations that is used for patient education when they go for ambulatory healthcare experience visits in the affiliate clinic. So it is really my honor to remind or to remember these students who may not be here in person, but I will be reading those names. Pratiksha Khanna. Maheen Khan. Joseph Bomenshaw. Teja Ginjupalli. Nicolette Okoro, Juliet Jordan John, Chizom Ogbugbu, Bertrana Juan, Radwana Rinta, and Tyler Rigord. Thank you.
Thank you, Dr. Mehta, and congratulations to all of our awardees who are currently working on another phase of their medical journey. It is now my distinct pleasure to be part of the inaugural Learning Community Awards. The first award is for the Learning Community Student Leadership. This award is presented to a student leader in recognition of peer leadership, engagement, and overall contribution to the development of the learning community. The winner met the eligibility criteria for the award as an LC student representative, and the awardee exemplified community spirit and made substantial contributions towards the development of the learning community. The winner was nominated by the LC leadership and was judged on a portfolio highlighting LC activity engagement. The winner of the LC Leadership Award is Kelsey Sapita. We have a plaque which we will be putting in the student support corner downstairs at LESC first floor, and Kelsey's name is going to be the very first inscribed on that plaque. The second award is for the LC Colleague. This award is presented in recognition of the colleague who has made an outstanding contribution towards the development of the learning community. And the winner of the LC Colleague Award is Miss Rachel Scott. Again, Ms. Scott will be the first colleague whose name is inscribed on the plaque. And last but not least is the LC Community Engagement Award. This award is presented to the learning community in recognition of its level of involvement and impact on its community partner through community service by the members of that learning community. And the winner of the LC Community Award is LC4, whose SCA is Miss Irene Alexander. Will Benson Gladison, the LC4 SGA representative, please come forward? Thank you. Congratulations to all awardees tonight. I wish to thank the Learning Community Awards Committee, which comprised of a representative from the SGA, Office of External Affairs, the staff, student support, and student affairs. I wish to thank them for their willingness to give of their time and for their support and hard work. Now, in closing, congratulations again to every individual and group who was honored here tonight. To reach your peak level of performance and to become the best physician possible, we know it takes significant focus on not only academic excellence, but also a keen focus on your own well-being, a commitment to social and community engagement, and personal and professional development. I want to thank the Student Government Association, the Office of External Affairs, and Student Affairs, as well as our presenters here tonight, for helping us to take this major step in expanding how we celebrate your achievement as student doctors. I look forward to even more awards in the future. Before we close, I have one final request of you. Celebrate. Now that we conclude the formal part of our program, take some time to celebrate this achievement with your colleagues and faculty over some food and drink, but not too long. Although it is extremely important to pause, reflect, and acknowledge these milestones, it's equally important to continue your focus on the ultimate prize. For you, the sky is the limit. We are very proud of you and look forward to seeing you next time. Once again, congratulations.